Assalamu alaikum. Welcome everyone on board. Uh, we just finished our discussion about opioid-free anesthesia in last three sessions. Actually, some of the topics with reference to out of non-operating room anesthesia were left. So I will just try to have some discussion about endoscopic procedures in urology suite and endovascular procedures in angio suite um, in preceding in coming days. Okay, so before we just start, any any question from the previous discussion? Anyone wants to ask any question? Yes, please. Am I audible to you? Can you hear me? Anyone wants to ask any question, or should I just start? Sundas, you are exam candidate.
Yes, sir.
Okay, so if it is possible to you, just answer the question so that it will be a practice for you, because this topic which I am discussing can be asked in your table viva, as well as even with reference to long case. Even I had this scenario of a patient for TURP. So actually, some of the concerns are related to lithotomy position. Okay, so let's start. Actually, like the the endoscopic procedures with reference to urology, usually what are the common causes? What are the common indication for which these urological procedures will be done? So it will, like we can say, cystoscopy. Okay, cystoscopy for either with reference to any growth or stone in the bladder. Then it, as a part of there are some procedures following that. There are check cystoscopies. Okay, so only check cystoscopies. Then in some bladder condition, they inject the Botox injection. Then of course the stones are there, and stones may be from there. Even for in ureter or in the kidneys. Okay. So with reference to the removal of the stone, either it is being done by laser or it is being done by the air therapy, which lithoclast, with which they are doing with the pressure. Okay, the pressure waves. So like if it is laser, so concern with the laser will be there. So according to the location of the stone, the level of anesthesia will be required. Okay. Usually these procedures, majority of people, they are doing it in with the general anesthesia. But actually, if it is in the stone, is in the lower part of ureter, or if it is in the bladder, it can be done under spinal as well. The Other than spinal versus GA, the actually the problem which the people face while they are breaking a stone is that they want the field to be static. Okay, so sometimes even if you are in the spinal, actually the problem is that sometimes patients cough, sometimes patient is moving. Okay, because even if you have achieved the block up to T4, patient can cough, patient can have respiration, deep breaths or less. So these are the problems that they want static field. Even if you have given GA, sometimes they will ask you to have decreased ventilation. Okay, so maybe you need to decrease not only the tidal volume or and also the rate. okay, within the limit that the CO2 is maintained. Okay. So this thing, it should be in your mind that at any point of time they can ask you to decrease the ventilation, because when they are at a critical position, when they where they don't want the patient to move too much or the lungs to come in that field or distracting their target. Okay. So this thing should be in your consideration that whenever you are planning the anesthesia. Okay. So these are some of the things. Of course, there may be, if they are bladder procedures, so they may be with reference to paraplegic patients receiving Botox injection, or there may be cancer. Okay. So as part of course, TURP or TURBT. Okay. So we will discuss TURP in a separate discussion. I have discussed before, but at the moment, I'm just trying to focus on other miscellaneous procedures. Then a number of times they are coming for either DJ stunt placement or removal. Okay, so this is again a short procedure, but maybe the DJ stunt was placed with reference to uropathy, obstructive uropathy. Okay, so obstructive uropathy may be reversible or irreversible. So if it is chronic kidney disease, so concern with reference to chronic kidney disease should be in your mind. Like this is just a mind map. So you should be, of course, not everything will be there in every patient, but whenever you are just revise whatever I have told up till now, that you are working in lithotripsy, because in some hospitals there is dedicated lithotripsy unit. Okay, where they are not only doing the lithotripsy, they are doing day case surgeries with quick procedures, which are being done for small short procedures. Even some inpatients they are coming for, so they are away from the main ward. In our hospital, there is lithotripsy unit, and they are doing URS, ureterorhinoscopy, URS procedure with the stones, and usually these are not very complicated stones, single side, okay, and like limited procedures, which all the concerns with reference to day surgery will also come. Okay, so if the patient is on chronic kidney disease, maybe the concern with reference to dialysis. Okay, so of course, all the concerns with reference to chronic kidney disease, multisystemic involvement, like so this is just a buzzwords for you, that even if you are dealing with any case, you should have these things in your mind. Okay. Of course, if a patient is dialysis dependent and some disorders, okay, like anything critical, they then maybe not done as day surgery. But you will find a lot of old age patients who are coming for removal of digestant. So they are not done as like inpatient, or they are not done in main ward. So sometimes you are just dealing it. So in majority of times they are doing it with mild sedation only. So in that case, like I told, what with all the cases, try to have local wherever and whenever possible. So with this reference, you should have asked the surgeon to have proper lubrication with lidocaine and give enough time, okay, before they put their scope. So this is the message for all the juniors and all the people who are practicing it, said that if you give some time, then it will become easier for you. Similarly, of course, you can have some anxiolysis with either of midazolam or Presidex, whatever you want to give. So this is the thing. Another important thing with this reference when you are dealing with this patient are the vagal reflexes. Okay, like the vagal reflexes which can occur with anal procedures or abdominal procedures. Okay, with the stretch of mesentery. So similarly, vagal mediated bradycardia can occur in these procedure as well. So you should be knowing about it. Another important point which should never forget, that usually they are using the fluid which can be cold. So it can result in hypothermia. Okay. So make sure the fluid which they are using is not cold. So because it will create a problem. This is one point. Then another important point we should be thinking, that usually the field which you are seeing in the monitor, is only very small area. Okay, and usually there is water is going with pressure. So usually, even if there is bleeding, sometimes it can remain hidden. Okay, so make sure this thing should be in your mind, that you check the abdominal distension. Okay, or abdominal girth. Just check the abdomen. Okay, because if, for example, there is any injury to any area, usually they are using it with the flexible scope, but of course with the guide wire anything can occur. So a very small thing can help you, that you should have a look on the abdomen. Okay. So sometimes you can have the problem like this. Even in TURP, there are cases in which the bladder is ruptured, and because of distension, because of anything they are doing. So this thing should be in your mind. So always keep an eye on it. Okay. So these are the main points which should be focusing whenever you are in the endoscopy unit and you are doing these procedure. Another, of course, with reference to lithotomy. Okay, the concerns with reference to lithotomy, the the provision of creating, we had discussed in detail all the positions related to anesthesia. So lithotomy is one of them. Okay, so of course, with reference to the limitations, that maybe whenever you are doing it, you should be knowing what is the natural uh, joint range of movement. So you don't try to do it beyond that. Okay, then another thing is that there are some nerve injuries which may be associated with later on. When they create it, there is auto transfusion of blood in the body, in the central circulation. So any patient who is at risk of, like they have limited cardiac function, so this extra 300, 400 ml of blood, which is coming in the circulation when they create the lithotomy, or in the other way around, when they reverse it. Okay, so it is just like losing 300 or 400 ml of blood. So transiently, even transiently, usually in normal patients, this is insignificant. But any patient who has problem, autonomic problem, or any patient in which the reflexes will not be that good. So in those patients, you can have problem. Okay. So these are some of the points which I just wanted to highlight to you. Lithotripsy, actually, it is what is called as ESWL. I don't have much experience of extracorporeal um, shock wave lithotripsy. Okay, so usually again, it's not a very painful procedure, but still they can. It's some patient will be requiring general anesthesia. And before, maybe once upon a time, of course, I have never seen this thing, that they used to immerse in the fluid. I don't remember. I read some way back many years ago. So they used to put it in a sitting position, or even if they are doing this lithotripsy, again you need patient not to move. Okay, so for that purpose, sometimes some patients are not cooperating, and they need to do it under general anesthesia. Otherwise, usually if the patient is cooperative, they can do it with mild sedation, or even in awake patient they can do it, because it's not a like too much painful procedure. Okay.
So, but it is painful for some patients. Some patients who
Yes,
have
yes, of
low
course.
threshold for pain, they do feel a lot of pain.
Yes, you're right. You're right. But actually, you can say that it's sometimes you require and general anesthesia. Otherwise, with mild sedation, you can do it. Okay. So I have limited experience about it, so I cannot comment too much about this procedure. Okay. So any other point, Zishan, Sundas, any question you came across while preparing for your exam with reference to this special endoscopic procedure? Yes,
So, have we discussed about the level of block required for ureteroscopy?
yes. Level of anesthesia, you actually up to, they are going up to kidneys, they require a block up to T6. Okay, so ureters. Distal ureter, it will be, I think, T10 or T8. Just correct me if I'm wrong.
Yes, sir, it's like this. Yes. Mostly, if it is a ureteroscopy, like URS ICL, when they have to break the stone, and if the
Hmm.
stone is at the ureteric junction, then spinal is mostly enough. But if
Yeah.
the stone is in mid ureter or something like that, then GA is preferable because
Actually, we
spinal won't
discussed
cut
this
it.
point, Zishan, we discussed this point with reference to the patient not moving too much, and with reference to the static environment they sometimes require when they are breaking it. Okay. So another point with this reference is that if the patient has stones and some part of some metabolic problem, so the concerns with reference to that metabolic problem with the involvement of liver or other problems may be there. Okay, so like these are main points which I wanted to highlight. Let me see if there was a today I did not open. I did not find any. We will just see. Just a second, please. So I had some. I think some of the articles with reference to cystoscopy. I remember I had some. No, I think not. So uh, I think that's what I wanted to discuss with this reference. Any questions or any comments? Endoscopic cystoscopy can be performed with a flexible fiber optic under local anesthesia with or without sedation. Rigid cystoscopy is indicated for diagnosis of lower GU pathology or dilatation of urethral. Yes, yes, yes. Strictures. Yes, strictures is also, and usually it will be following trauma. Okay. But it can occur in any other patients. But usually stricture or with the dilatation is another procedure which is done. Okay. So ureteroscopy is used
Optical
to outline the
ureterotomy.
I'm sorry.
Optical ureterotomy is done for strictures.
Yes, yes. It is there in pediatric patient as well. So if they are pediatric patient, so the concern with reference to pediatric age group will be there. Okay. Percutaneous stone removal. Okay, so thank you very much. Today it was a short discussion, but actually sometimes we can miss some of the important points. So I think I will stop here, and tomorrow, inshallah, we will try to have some endovascular procedures. Okay. So thank you very much for your Sundas. This question can be asked to you in the exam that any patient
Yes,
going for cystoscopy, what are the anesthesia considerations? So don't worry about it. You can make your answer with the reason for that this procedure concerns with the age related lithotomy position. So your answer will be finished. Okay. Was it sort of
yes, one.
this? Usually this question is
So,
not written in all the books. So sometimes you can miss. Okay. So
Yes, sir.
yes, Zishan.
sir, I've
Yes.
seen a few people perform TURP under saddle anesthesia. What is your opinion, or what is broadly an opinion about it?
Okay.
Because I
Actually,
see
with reference to TURP, the thing is that actually, if for example, surgeon is good enough, okay, and he is able to control the bladder distension. Actually, even when I started my training, I see all the old anesthesia doctors mainly like they used to do it in saddle. I have done many times saddle in early part, but later on, maybe I was whenever I face a problem, then like so some people do in between that they give saddle in the way that they don't let the patient sit for 10 minutes, for example. Okay. Maybe they give a relatively high dose, and then they let the patient sit for some time, and then they let the patient straight. So maybe they achieve the don't have the too higher block. But usually, if you ask me, it can be done. But in the exam, never tell this. Okay. It depends on, because TURP we will discuss inshallah some other time. But TURP, because with reference to TURP, if you just think that with reference to TURP, you should be knowing, because in new time they can ask you, Sundas, a question for you as well. What is this question was asked in a mock exam? So I will, because we finished quite early, so I can share with you what is this question for you. What is gynecological TURP? Have you heard about it?
No, sir.
No, sir.
So do you know about uh, myomectomy, which is being
Yes, sir.
done? Okay, so it is
Yes,
that
yes, sir.
one. So
Removal
it is
of
the same,
fibroids.
yes, the same concern with reference to irrigation fluid and absorption of fluid can occur.
Yes,
Okay,
sir.
so this is one of them. Again, the same concern with TURP is the development of TURP syndrome with reference to the fluid. Okay, because
Yes, sir.
recently in many setups they are using with the laser. So with the laser they are using with saline. Okay, so the things are totally different. Usually it is reserved for the prostates which are large in size, but actually they take a lot of time, and they are not concerns related to the fluid absorption. So rest of the concern will be there. So they are doing it in the same lithotomy position, same hypothermia, but they are not doing it with the fluids which are creating problem. Another important problem which we face with TURP is obturator reflex, and for that actually either obturator nerve block or use of general anesthesia. Then maybe especially if the tumor is in the lateral wall of urinary bladder, this will create more problem, because when they are resecting this, the obturator nerve is involved and there is obturator reflex. Then another problem is with reference to the erection which occurs during the procedure. So actually sometimes it creates a big problem while they are proceeding with it. So you should be knowing how to deal with these problems. Okay, so thank you very much. Inshallah we will discuss endovascular procedures tomorrow. Okay.
Thank you, sir.
Bye bye. Assalamu alaikum. Thanks a lot, all of you, for joining.